All right, recording. All right, as agreed, we are going to cover adult congenital heart diseases today. And as also mentioned, the topic is huge, huge, huge. And I'm not sure if everybody has opened the guideline. If you open the guideline, it is very, very, very big. However, just because it is big does not mean that we should not cover it or try to cover it, right? So we are going to try to cover some of them today, and what we're going to cover um, will be the common ones and statistically common ones, and of course there are so many others as well, right, that can happen as well, but we're going to cover them common ones simply because there's a higher tendency for us to encounter such patients. So now before we go into um, great details on each diseases or and everything and changes and how to manage such patients, we need to understand why we are covering adult congenital heart diseases and why the term adult is included to it. And it sounds a bit like an oxymoron, like adult then congenital. Why is it considered adult? Why is it not pediatric? And most of the time when it comes to congenital heart diseases, especially when it comes to the heart as an important organ, it is weird that it occurs in grown-ups, in people um, who are of an older age as compared to peds patients. So the reason why this happens and the reason why they have coined this term adult congenital heart diseases is because a lot of times some of the congenital heart diseases, which actually occurs most often previously in, in, in children, in pediatric patients, but because some of them are asymptomatic or maybe misdiagnosed or too small to even diagnose, and oftentimes over time, um, it it develops into something bigger, and it only becomes symptomatic when they are adults and when things become bigger and more serious. And so most of the times it's because of misdiagnosed, or because it is asymptomatic, and that is why it progresses into adulthood, and that is why it is only detected in adult patients as compared to in children. uh, However, the range of diseases that we are going to cover um, will still be the same in adulthood and in adult patient, and also in peds patient. And the guideline that I sent to everybody, that covers adult congenital heart diseases and not peds. And in the guideline, if you if you have read a few the early pages of it, it's stated that it is a revision, or it's an updated version of the 2010 um, guideline, and this the one that I sent to everybody is the most updated one, right? 2020 version. And mainly because over time they've discovered new concepts and discovered a lot of nuances and a lot of caveats when it comes to each congenital heart diseases, and they've discovered several mechanisms as to why certain things happen, and there are also some differences in there are also some better approaches when it comes to treatment of certain congenital heart diseases, and especially when it comes to surgical intervention and surgical treatment that we perform, especially uh, percutaneous intra PCI, percutaneous intra something PCI. What does it stand for again? Uh, Percutaneous intervention. Yeah, PCI, percutaneous intervention techniques, and they are because of some discoveries that they found when it comes to mechanism, the PCI techniques are different. they've kind of updated it. Also, I would like to and again emphasize, or would like to still emphasize the importance of prenatal and postnatal care, especially in obs and gynae, and especially for pregnant women, the importance of prenatal care and intranatal care as well, and postnatal care, because as I've already mentioned, the reason why a lot of pediatric or childhood congenital heart diseases develop into adult congenital heart diseases is because it's being misdiagnosed, or it's too small to even diagnose, or it's asymptomatic. And even if with proper prenatal care and prenatal examination, it can be missed. Even with that, it can be missed. So you can imagine what happens if patients don't even go for prenatal cares, and it does not get detected at all. And even if it becomes symptomatic, no proper prenatal care, how do we want to detect that, right? So statistically, according to the guideline, the incidence in as of 2020, as of last year, uh, it is it it was estimated that approximately 9 out of 1,000 newborns have congenital heart diseases, and the numbers are declining. The numbers are declining in developed countries, mainly because of technology and stuff like that, and increased screening, and also improvement of screening methods and techniques, and also the unfortunately some congenital heart diseases end up in the termination of the pregnancy. So in such case, uh, the the occurrence or the incidence decreases. Yeah. So uh, however, even when they are symptomatic or asymptomatic, a lot of such patients survive with treatment, without treatment. Most of the time, a lot of them survive, and even in the future, even in the future, there is a risk for it to develop again, and a lot of them do develop again when they grow up. So this therefore increases again the prevalence of adult congenital heart diseases. I remember when I was in fifth year, about last year, before COVID. Last year, when we were doing surgery for fifth year, I was given a task, a project for finals. Uh, I was given a patient to study, and it was not just given to me for the sake of for the sake of for fun or anything. It was given to me because of special reasons. And this patient actually has aortic stenosis, which is congenital. So in other words, congenital heart diseases, and with aortic stenosis, it was detected that it was confirmed that it was congenital, alongside a lot of different arrays of diseases of the heart. This guy has a lot of heart problems, had multiple MI attacks. He had several episodes, he had history of heart failure and stuff like that. A lot of his valves have stenosis. Also, some of the valves are insufficient. In other words, there's regurgitation, a lot of regurgitation and all that. And he was a candidate for heart transplantation. He, however, does not want to undergo transplantation. He, how, yeah, he did not want to undergo transplantation, and he wanted to only undergo conservative treatment. Although obviously his science and all that were degrading and stuff like that. And honestly, when I saw the patient, it wasn't nice. So that was like one of the patient that I've seen when it comes to congenital heart diseases. So it's not that it does not occur. Even you see from the numbers itself, it's approximately 9 out of 1,000 newborns, and I can't find any numbers for adults. But seeing how I've met one patient at least in medical school, it means that, well, somewhere somehow it still occurs, right? Right. Also, I would like to emphasize that the death, neonatal death, when it comes to congenital heart diseases, or with neonatal death caused by congenital heart diseases, they the numbers are increasing, unfortunately, in underdeveloped countries. And well, when we already talk about neonatal congenital heart diseases, what more to say adult congenital heart diseases, when they are asymptomatic and all that, right? And the numbers are increasing as well in underdeveloped countries. So again, this brings us to how important to the importance of having access to medical um, technology, have access in specialists for expert medical uh, care, especially from experts. And the disparity between developed countries and underdeveloped countries is huge, and if we don't do anything about it, and if we can't achieve medical equity, this would definitely be a problem in the future. All right, so with that, that is sort of like a background as to how severe or how relevant this issue is. It's just because it seemed that it's kind of, the numbers are not as big as the numbers as patients with MI or heart failure. We should not overlook this disease as well. So uh, before we move on to the three congenital heart diseases that I've mentioned to everybody, yeah. Of course, we need to classify such diseases, and unfortunately or fortunately, whichever, I don't know what it is, the classification for congenital heart diseases is a bit complicated, and I would like everybody to pay attention to the classification. I've tried to compile as many classification as there is out there, and try to put them in a manner that everybody can understand, and in a manner simple enough, at the same time not too simplistic, for us to understand, for us to study from different sources. And don't worry, the sources that I got from, they are reliable, and they are from USMLE exam, board exam. They are from MRCP. They are from PLAB exam. They are from the guideline itself that I sent to everybody, and they are also from the textbook that we have for therapy. Although the textbook can be a little bit old, but well, it's something. So anyway, I hope you guys are ready for the classification, yeah? So before we classify, let's talk a little bit about etiology, as we see, or as we understand congenital heart diseases. Also, from the name, it's a congenital, so the root can be genetics, of course, but most causes of congenital heart diseases is idiopathic. We don't know, so most causes are unknown. However, it was discovered that there is a strong correlation, a strong correlation between association between teratogens, exposure to teratogenic material for the mother, and the development of congenital heart diseases. Such teratogens include smoking, alcohol, um, a number of infectious diseases, and mainly rubella. And you know that um, uh, girls will have to get rubella vaccination, right? and for this reason as well, for to as a it's a form of prophylaxis for congenital heart diseases. I was actually vaccinated for rubella when I was in high school because there was a rubella outbreak, and just because girls get vaccinated does not mean that guys can't get vaccinated, and guys can be affected by rubella as well. There was an outbreak in my school, and the whole entire health state, healthcare ministry was shook by the outbreak, and they sent people down to vaccinate us. Anyway, uh, teratogens, yeah, as I mentioned earlier. Next will be genetic predisposition, predisposition, trisomies, Down syndrome, trisomy 21 and stuff, a lot of other trisomies as well, Marfan syndrome, Noonan syndrome, and DiGeorge syndrome. They are also highly predisposed for congenital heart diseases. All right, with that said, let's go to our classification. Now, if you read up on congenital heart diseases, you'll find that some textbook or some sources will try to compile them, try to try to match them so as to make everybody understand better. I try to do that too, and I can see that the authors are also trying to. But most of the time, I feel that the more you try to match them, the messier it becomes. So you see what I mean later on. So anyway, um, there are different ways to classify them, and for different reasons. The common one will be cyanotic and acyanotic. Cyanotic and acyanotic. From the name, you know what it means, right? Cyanotic, it means that it causes bluish discoloration on the body, extremities and stuff. Acyanotic would be absence of such occurrences. It can be pale, but it can also be pink. Acyanotic. Second is the occurrence of shunting. What is shunts? Shunt means that something is delivered from one side to another side, right? So shunts, it can be left to right shunting and right to left shunting, or mix. Next next way to classify is it's being stenotic or regurgitant, just like valvular heart diseases. There's stenosis and insufficiency or regurgitation. So it can be stenotic, regurgitant. Now, based on the ESC guideline 2020, I could not find such classification there, but they classify it according to severity, which we are going to see a little bit later. And the other classification, the cyanotic, acyanotic, shunting, stenotic, regurgitant, they are mostly in textbooks, and they are mostly for, I took them from board exam material. So I guess that's worth studying from. Anyway, let us start with cyanotic, acyanotic. Okay. Again, 1 second. Let me just show this to everybody, and everybody will see. Screen share. Okay. Everybody can see this, yeah? I should put it bigger. Okay. This is based on the ESC guideline. As I mentioned earlier, they divide it into mild, moderate, and severe. That's it. And you can see how many congenital heart diseases there is right there, like a million, not really a million, but a lot. So you see here, mild, moderate, severe. Now, as I talk about cyanotic, acyanotic, shunting, and stenotic and regurgitant, I want you to find which place it falls under, that particular disease falls under. It might fall under mild, might fall under moderate, might fall under severe, according to the guideline. Okay, I wanted to copy this entire table into a Word document and highlight and put different colors and all that for us to see which one is cyanotic, which one is acyanotic, which one is shunting, which one is stenotic and regurgitant. But I did not find time to get that to do that. So maybe you can do that too yourself. Anyway, now let's start with cyanotic congenital heart diseases. A very good acronym that we can follow is 5 T's. 5 T's. Number 1, tetralogy of Fallot, Fallot, F-A-L-L-O-T, tetralogy of Fallot. Next, transposition of great arteries, tetralogy of Fallot, or TOF in short, transposition of great arteries, TGA in short. And the third T, tricuspid atresia, A-T-R-E-S-I-A. The fourth T, truncus arteriosus, The fifth T, total anomalous, A-N-O-M-A-L-O-U-S, total anomalous pulmonary venous return, or total anomalous pulmonary venous connection, the same thing. In short, TAPVR or TAPVC, the same thing. These are the 5 T's of cyanotic congenital heart diseases. Others can be, another one that is not a T is pulmonary valve stenosis. Pulmonary valve stenosis. These are the common ones, okay? Most common ones. Now, talking about things being common, the most common cyanotic heart diseases overall is tetralogy of Fallot. Tetralogy of Fallot. But the most common cyanotic heart diseases at birth is TGA, transposition of great arteries. Why is it only at birth? Because tetralogy of Fallot normally is commonly only detected about 1 or 2 months after the murmur is the heart murmur is identified, and it occurs most often amongst neonates approximately 6 months old. But at birth, transposition of great arteries is common. Got it? Can we move on to acyanotic? Okay. Acyanotic heart diseases. There are your defects. Which defects? Ventricular septal defects, VSD, ventricular septal defect, ASD, atrial septal defect, your PDA, patent ductus arteriosus, your CoA, coarctation of aorta, and your aortic valve stenosis. Your aortic valve stenosis, which I told you earlier on, the patient that I was given had. Now, the most common acyanotic congenital heart diseases is your VSD, ventricular septal defect. It occurs about 30% of everything. However, according to the guideline, this guideline that you're looking at, now atrial septal defect is now more common in adults. More common in adults. Everybody got it for acyanotic? Okay. Let's move on to shunting. Shunting. As mentioned earlier, there's left to right, right to left, and mix. Yeah? Now, left to right, shunting. It includes your PDA, your VSD, your ASD. And also another one called endocardic cushion defect. If we have time, maybe in the future we'll cover that. Endocardic cushion defect. So left to right includes your PDA, ASD, and VSD. Right to left shunting. Your tetralogy of Fallot, TOF, Epstein anomaly, and tricuspid atresia. What is atresia? Atresia means absence of something. So tricuspid atresia means absence of your tricuspid valve.
What's the second one?
Epstein anomaly. You know, like Epstein-Barr virus, EBSTEIN, Epstein anomaly. Mixed shunting. Truncus arteriosus. Sorry?
Can you repeat on the anomaly thing again?
Epstein anomaly. And then next is tricuspid atresia.
I think you're not here. Can you spell it if you don't mind?
Oh, okay. Chats. Right, it's in the chat. This is right to left. Okay. Next will be mixed. Mixed is truncus arteriosus, your TAPVC, your total anomalous pulmonary venous connection, hypoplastic left heart syndrome, HLH syndrome, and your TGA, transposition of great arteries. These are all your T's just now for your synoptic heart diseases. Got it? Okay. Next, these are all shunting. So without shunts, stenotic includes, of course, your aortic stenosis, pulmonic stenosis, and coarctation of aorta, CoA. Last but not least, regurgitant. Just like your valvular heart diseases, your insufficiency. So it means all of your valvular heart diseases, it's under here. Your pulmonic insufficiency, mitral insufficiency, aortic insufficiency, tricuspid insufficiency, it falls under this. If you want to write it simply, you can just write PIAIMITI, you'll understand. Another one is your mitral valve prolapse. That's also under regurgitant. Now, why did I say that the classification is complicated as you see here? A lot of authors, the books that I've read, they try to mix them up together. Try to like compile them so that it's easier for people to understand. The things that I've read, according to our therapy 5th year textbook, according to that book, it says that left to right shunt, diseases that fall under left to right shunting, is acyanotic. Is it correct? Is it not correct? I have to be honest, I don't know. Because I don't see it in other books. According to USMLE and several other books as well that I've read, okay, then this probably has a higher tendency for it to be correct. Right to left shunting, they are cyanotic heart diseases. However, if we want to generalize such classification and cross match them, you see that right to left shunting, tetralogy of Fallot, Epstein anomaly, tricuspid atresia. But you see your cyanotic heart diseases, your truncus arteriosus, your TAPVC, your TGA, they are cyanotic, but it falls under mixed. So to say that all cyanotic heart diseases involve right to left shunting, is that I think that would be an overgeneralization. So after learning all this classification, and the topic itself, congenital heart diseases, is also still understudied. It's also still understudied. If you read the guideline here, let me show you something. There is a part at the end of the guideline that talks about the concepts and the things that are still understudied, and people need to put a lot of funding and a lot of manpower to study them. So it's something that's worth considering if you like to go into cardiology. That is to develop and to understand congenital heart diseases better. Okay, however, what I'm going to try to, I've decided to do this evening is not to match them and to lay everything out and to let you decide which one is which. And as you study more and as you read up on congenital heart diseases, you read them up definitely with some grain of salt, take them with a grain of salt, and have this what we've covered today laid out in your head and in our minds, and develop it on your own as well. All right. Any questions so far before we go into the 3 diseases that I talked about? No? Хорошо. All right, let us start. Which one should we start first? Let us start. All right, let us start with tetralogy of fellow. Let's start with tetralogy of fellow. From the name itself, tetralogy, tetrad, right? It means it consists of four components. Four components. Number one, VSD. VSD, ventricular septal defect. Non-restrictive type, ventricular septal defect. Second, right ventricular hypertrophy. Right ventricular hypertrophy. Next, one second, I need to show you. Right ventricular, oh, where is it? Right ventricular, I want to show a picture. Right ventricular outflow tract obstruction, RVOT obstruction, or RVOTO, RVOTO obstruction, and or pulmonary stenosis. This is still under the second one. Right ventricular outflow tract obstruction and/or pulmonary stenosis. And the fourth component is overriding aorta. Overriding aorta. We'll talk about them one by one. Are you excited? We'll talk about them one by one. Right, ventricular septal defect. So as you can see in this picture, yeah, ventricular septal defect. You see here, ventricular septal defect. This is the septum, ventricle, there's a hole. Right, there's a hole. So there's not much to explain here. It means that it's, I think, pretty self-explanatory. Second is right ventricular hypertrophy. You see here, right ventricular hypertrophy. Pretty self-explanatory too. And we'll talk about how this develops. Next, third one is right ventricular outflow tract obstruction and/or pulmonary stenosis. Now this I have to explain. What does that mean? Right ventricular outflow tract obstruction. As you can see here, this is your right ventricle, yeah? And normally this should pump out blood into your pulmonary artery, your pulmonary trunk, yeah? Both left and right. Then, but the problem is that this tract over here, your right ventricular outflow tract, is obstructed. Is obstructed by what, you may ask? By what, you may ask? By tissues, unfortunately. There's some outgrowth of tissues along the tract. Now, you see here, tissue obstructing the right ventricular outflow tract over here. This one over here, this thing. This is the tissue, and you can say it is sort of like an extension of your pulmonary trunk. This is the tissue that's growing on the tract. This supposed this tract right here. Now, you see also this is the pulmonary valve, yeah. But this growth, this tissue that's obstructing the tract is under the valve. So such obstruction is called infundibular or subpulmonic or subvalvular, the same name, obstruction. This right here, under the valve. Infundibular, subpulmonic, or subvalvular. Another type is valvular obstruction, which is on the valve itself. I could not find a picture for that to illustrate. And the third type of obstruction is called supravalvular. From the name itself, you understand it's above the valve. Supravalvular obstruction. So infundibular, valvular, and supravalvular obstruction. And a lot of times, because of such growth, it causes narrowing of the valve, which results in pulmonary stenosis. That is why the third component is RVOT obstruction and/or pulmonary stenosis. Now, understanding that the valve is now small, or even if there is no pulmonary stenosis, the right ventricular outflow tract is now blocked or obstructed. It means that there is some form of pulling of blood in the right ventricle. Pulling of blood in the right ventricle, which causes these tissues to, of course, compensate by undergoing hypertrophy. That is why you see right ventricular hypertrophy. Now, because of this as well, as you understand already from the classification, tetralogy of Fallot is under cyanotic heart diseases, right? Your 5T. And also according to under the classification when it comes to shunting, according to USMLE, cyanotic heart diseases fall under right to left shunting, right? So tetralogy of Fallot, in other words, one of the feature, of course, from the classification, as we understand the classification, one of the feature, number one is cyanotic, number two, right to left shunt. What does that mean, right to left shunt? Where is blood moving? It's from right ventricle to left ventricle, because the right ventricular muscles is now thick, so it's pushing blood more to that. It's trying to push out blood more, so it's pushing into the pulmonary trunk and also into your left ventricle. So that is why the shunting is right to left. Next point is, next component of that is overriding aorta. Overriding aorta. Now, what does that mean? Overriding aorta. Let me show this to you. Overriding aorta. Now, on this side is your normal heart, and on this side, the one in the box B, is your heart in tetralogy of Fallot. Now, what does that mean? Overriding of aorta. It means that the aorta, especially the ascending part of the aorta up to the arc, because of the ventricular septal defect, it's moving towards, it gets shifted towards the right side of the chest, and it looks as if it is sitting over the defect instead of sitting over the left ventricle. See, normally it's sitting over here, nicely sitting here, but now because of the defect, and 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 it being heavier, now it's sitting over the ventricular septal defect. So that's what it means, overriding of aorta. Okay, clear? Now we now understand what all four components of tetralogy of Fallot mean. All four of them. VSD, your right ventricular hypertrophy, RV or TO, plus minus pulmonary stenosis, and your overriding of aorta. So the severity of this disease is highly dependent on your RV or TO. The more severe your RV or TO is, the more cyanotic that patient is. If the RV or TO is not that severe or mild, the patient may not even be cyanotic. The patient can even be pink. So in such cases, they are called pink TOF, pink tetralogy of Fallot, instead of cyanotic blue, the typical tetralogy of Fallot. Now, what else can you find? What are the features of tetralogy of Fallot? We talked about cyanosis. We talked about right to left shunting. Third feature is systolic murmur. Systolic murmur, no, as you expected, right? When your pulmonary valve is stenos, that means because what blood is now flowing through it in a turbulent flow, definitely murmur is it's natural for murmur to be heard, right? And so systolic murmur, well, obviously systolic, you understand why it's systolic, and due to the pulmonary stenosis. Remember, the murmur, systolic murmur, is heard because of pulmonary stenosis, and it's not because of the ventricular septal defect. Of course, logically, because of the defect, we understand now blood is also supposedly turbulent there, right? But according to findings, the murmur that we hear is because of pulmonary stenosis and not because of your VSD. Why? I don't know. Fourth component, you will see that the aortic arc is now bent towards the right side, as we also already understand, overriding of aorta, the fourth component of your TOF. Fifth feature is on X-ray. We will see boot-shaped heart, which I am going to show. Right, as everybody can see. This is a boot-shaped heart. Number one, you see that your right ventricle is thickened here. Now, because of this, um, the left ventricle, it gets pushed up because of the diaphragm. It gets pushed up because of the diaphragm. The left ventricle is now heavy, and the diaphragm over here is actually pushing this heart up. That is why you see that your left ventricle is bent upwards, while your right ventricle is now downward. And you can also see that your aortic arc here is sitting on the right side. So it looks like a boot. It's called boot-shaped heart. An ECG finding, of course, you'll see right ventricular hypertrophy as expected. Now, how do we treat such patients? Of course, as we see that this is congenital, the most common treatment is of course surgical. But as patient comes in, of course you can try to treat conservatively in preparation for your surgery. So the patient can be placed in a knee chest position, like what we learned in proper, the knee chest position, and you can give morphine for the pain as well. So to improve cyanotic episodes in the future or right there and then, you can give beta blockers as well. The beta blocker will reduce the infundibular spasm, as we talked about earlier on, the tissue that grows under the valve here, infundibular part. And because of the flow, that part can spaz too. And beta blocker can help to reduce such spasm. What type of surgical repair can we do? We can, of course, repair the defect itself, the ventricular septal defect. We can perform valvulotomy, and we can reverse the obstruction. We can remove, sorry, not reverse, remove the obstruction itself, the thing that's causing your RV or TO. And we can perform a shunt that is called Blalock shunt. Blalock shunt. What is Blalock shunt? It is an anastomosis between subclavian artery to your pulmonary artery. And because of this shunting or this anastomosis, post-op, after the post-op period for the patient will have a weaker left radial pulse, a weaker left radial pulse.
Man, can you repeat the name?
I'll type it in the chat. Blalock. Blalock shunt. So that's that. We're not going to cover in great details about surgery and all that because we are covering internal medicine, not surgical. All right, another one. As we understand, you see that the valves are now compromised. Therefore, as we learned before in endocarditis, whenever the heart is, the valves are compromised in the future, whatever it is, whenever the valves are compromised, we have to remember that we have to give endocarditis prophylaxis, which we've early on learned about the prophylaxis, right? And how severe it is. The table that we talked about early on. Next would be to also expect arrhythmias as well. And one of the things that is revised and new recommendation in the guideline is also to be aware of arrhythmias. So we have to have that in mind and to be ready for that. Also, we have to be ready for for clotting as well. So we have to give anticoagulants for a short period of time. If heart failure is seen, of course, we have to treat that as well. Pulmonary edema, and especially acute ones. Pulmonary edema is most often acute anyway. So we have to give diuretics and stuff like that. Okay. Now, any questions so far before we move on? No? Okay. Let's move on next to PDA, patent ductus arteriosus. From the name itself, let's understand the name, and as we understand the name, everything just falls into place. Ductus arteriosus, what is that? Another name for ductus arteriosus is called Bottle duct. B-O What is that? It is a blood vessel. Oh, sorry, I have a picture. It is a blood vessel that connects your pulmonary trunk, your pulmonary artery, pulmonary trunk, the same thing, to your descending part of your aorta. You see, this is your pulmonary artery over here. It's a blood vessel that connects your pulmonary trunk, pulmonary artery to aorta. PDA, patent ductus arteriosus. Now you already now understand what is ductus arteriosus. It refers to that vessel over there. But what does patent mean? Patent. Some of you might know that patent in a non-medical way, it means a body or a licensing figure or an organization that you apply from to get patenting rights. For example, you've invented something, then you are applying for a patent, patent, patenting rights for the things that you've created, so that nobody else can claim a name over it. If they already they are also inventing another name without even you knowing, or then they also don't know that you are also inventing it, and then suddenly they claim the name. So applying for such patenting rights will secure your name. But medically, that's not what it is. In medical terms, patent means an open or unobstructed pathway. In this case, of a failure for some things to close, so it remains open, right? So in other words, your PDA, patent ductus arteriosus, simply means that your ductus arteriosus is open. It's not it fails to close. It fails to close. So clear, right? What patent ductus arteriosus is. Now, not if patent your ductus arteriosus normally will close spontaneously after birth within about a week or so. Normally, it will just close on its own and just disappear. However, if your PDA persists beyond the first week, it is very unlikely for it to close spontaneously anymore. That is why the congenital heart disease or defect is formed.
Norman, can you
Mm.
repeat the last sentence?
If PDA persists, because PDA is physiological, right? It's physiological. The formation ductus arteriosus is in a child. But if your PDA persists for more than a week or beyond 1 week postnatal after the baby is born, it is very unlikely for it to close spontaneously. It will remain open. It will not close spontaneously. Okay, clear, yeah? Now, according to the ESC, the guideline, what I like about the guideline is that it's very specific, very specific. When I have questions in my head, I open it, everything is just there. Everything is just there. So, according to ESC, the patent PDA is between proximal left pulmonary artery connecting to the proximal descending aorta, distal to left subclavian artery. Distal to left subclavian artery. So from this definition, I tried to find pictures that are actually representing this definition correctly. The picture that I showed to you is not is unfortunately not following such definition.
Norman, can you repeat the definition?
Okay, I'll show you a picture that that I found the closest thing to it, and I'll repeat it. Is it here? No. One second. Very good. Okay, I'll show you this. This is the MRCP textbook. Okay, and this is the closest thing I can find to the definition that is in the guideline. Definition says that it is a blood vessel that connects from proximal left pulmonary artery. You see, this is the pulmonary arteria. Left, this is the left branch. Proximal, it's not too far in deep inside. It's just close to the bifurcation between left and right. Proximal left pulmonary artery, branch of the pulmonary artery, connecting to the proximal descending aorta, the proximal descending aorta, distal to the left subclavian artery. This is left subclavian artery over here, this branch, this small thing over here. Distal to here, distal, and proximal descending aorta. This is descending aorta already, and proximal means that the early part of it. So that is why I could, this is the closest picture that I could find. The picture that I showed to you just now definitely is not it. I don't know if you can see it over here. What? See? It's not even left, it's in the middle. It's not even close to it's not even proximal to the descending aorta. It's even like this is the subclavian artery. It's not even close to it. So anyway, that's what I want to illustrate. Now, risk factor. Females are more affected than males, ratio 2:1, and it is associated again with rubella infection, PDA, maternal rubella, if the mother has rubella. Again, I would like to emphasize on the importance of rubella vaccination. And it's also common in premature babies and babies that are born in high altitudes. I don't know if there are many babies born in high altitudes, but that's what the textbook says, born in high altitude. So let's just follow what the textbook says. Next, feature, right? Feature. So from the name itself, it says patent ductus arteriosus, and we understand that it has association with the descending aorta. So we can identify subclavian thrills. Over here, if thrills, you put your hand, like what we learned in propa. We can feel left subclavian thrills, and a murmur that is very characteristic for PDA is something called continuous machinery murmur. Continuous machinery murmur. What does that mean? It means that it's very rough, very rough, and it goes very rough, then disappears for a while, then goes very rough, like a machinery, like a car. Yeah, something like that. Now, next is shunting. Shunting. Initially, it's supposed to be left to right shunt, as we learned earlier on, right? Left to right shunt. PDA falls under left to right shunt. Which is logical. Which is logical. You see that the aorta, um, because of the aorta technically naturally has higher pressure, right? So it pushes blood out, and because of the presence of ductus arteriosus, the blood will now not only go across the aorta but also go through the ductus arteriosus, the PDA as well. And because of this, there's not enough blood, right? So the left ventricle and left atrium will try to compensate by working harder, right? So technically, because of this, it is left to right because the blood flows through the PDA into the pulmonary artery and goes back into the right ventricle. So technically, it's left to right for originally. However, over time, because of this, the pulmonary artery will now try to compensate such phenomenon. So there is some reconstruction in the vasculature of the pulmonary artery, causing it to be thick. And the pressure in your pulmonary artery now begins to increase. Now, because of the increase in pressure in the pulmonary artery, it shifts or reverses, such shunting reverses from right to left, now becomes, sorry, from left to right, now becomes right to left. This phenomenon or this syndrome is called Eisenmenger syndrome. You might have heard this before, Eisenmenger. It's when the shunting reverses, and it reverses because of pulmonary hypertension. There's too much blood already now, and causes backflow of the blood into the lungs and stuff, and because of that, the shunts will now reverse. It usually reverses only in large and moderate PDA. In small PDA, it does not really reverse. And many times when this happens, as you expect, right? This murmur that you hear is supposed to be systolic murmur, right? Now, because of this, the murmur now might even disappear absolutely because of this reversal of shunting. You might have heard them, you might hear the murmur in the beginning where you expect it to be on your aortic point. But after that, it might disappear completely because of the shunting. Or if it does not disappear, it might become softer, it might become shorter maybe, but it will be weaker, definitely. Now this is what we call Eisenmenger syndrome, the reversal of that, right? This is not only seen in PDA, as we probably will learn in the future. When it comes to the ventricular VSD and ASD, it also happens in those diseases too, your VSD and ASD. Understanding this, that your Eisenmenger syndrome can occur in PDA, VSD, and ASD. You might ask, so does it happen in tetralogy of Fallot? Because in tetralogy of Fallot, your first component is VSD, correct? The answer is no. They did not discover any reversal of shunting in tetralogy of Fallot. So that is what we have to remember. PDA, VSD, ASD, Eisenmenger syndrome, but not in your TOF. Next feature of patent ductus arteriosus is large volume bounding and collapsing pulse. Large volume bounding and collapsing pulse. What does that mean? Large volume. So when you palpate your radial artery, you feel that the pulse is strong. The artery, the pulsation, you can feel that the artery is big and very very strong basically. But what does that mean? Collapsing pulse. It means that it becomes so strong, then it disappears for a while. Then strong again, disappears for a while. So it collapses every time. For every pulsation, boom, then they disappear. Boom, and disappear again. So that's what it means by collapsing pulse. There's also pulse pressure difference. The pressure on your hand, on your extremities, might be different from your from your upper extremity and lower extremity may be different. Another feature is heaving heart, heaving apex beat. When you feel the apex beat, you palpate it, you palpate or listen or auscultate your apex beat. You might hear that the apex beat is now weaker or trying to like very tired, something like that. So how do we diagnose such patient, right? The gold standard, of course, would be to do CT MRI of the heart to properly see it. But other things that you can do if you don't have CT MRI is your chest X-ray. Definitely, you see increase in your pulmonary markings. You see that your pulmonary arteries roots are now larger. You see edema, pulmonary edema, as we understand because of Eisenmenger syndrome, and of course your cardiomegaly. In your echocardiogram is also important because you'll measure the pressure of your left atrium, your left ventricle, and you be able to check for your flow of blood in your aorta. Your ECG will also show ventricular hypertrophy. So these are quite expected, and so as you understand the mechanism of how things develop, you kind of know what to prescribe, what type of investigation you want to send, and what type of things that you expect in such investigation. If you don't understand the mechanism, then you're blindly looking at your ECG, blindly looking at your chest X-ray and echocardiogram. Now, how to manage and how to treat such patient? You can try to let it close spontaneously. So there's a possibility for it to close spontaneously, but also remember what I said earlier on. If PDA persists for more than a week, it is very unlikely for it to close spontaneously. So in such a case, we have to perform surgical closure of your PDA, either by ligation or to clip it at everything. If, like I said earlier on, it is also common in premature infants, right? So what do you do? Of course, if in premature infants, it's natural for PDA to still be intact, right? And it only disappears after birth. So what can you give for patients, for preterm babies, preterm infants? You give indomethacin. Indomethacin. It is an NSAID. how it helps to close PDA, I don't know. I don't know. I try to look around. Maybe I've not dug um, deep enough. Maybe you can read up on your own too, how it closes your PDA, how an NSAID can close PDA. So yeah, something that's worth reading up on. So that's PDA, right? Clear? Any questions so far? No? All right. We have 7 minutes. We can briefly go through coarctation of aorta, but actually it's quite a lot. Still quite a lot. Still quite a lot. Right. Okay, I don't have any pictures to show. Let's try and briefly talk about coarctation of aorta, and let's see how much time can permit us. All right, coarctation of aorta. You might have heard this before, and you might have some understanding of this or a rough idea of what it is, but let me debunk that that understanding. Some you might even reach to this understanding if you're already here, but it's fine. A lot of people think that coarctation aorta simply means narrowing of the aorta somewhere, a narrowing of aorta, but no, it's not just a narrowing of aorta. Now, what is coarctation of aorta? According to the guideline, the 2020 guideline, it is a generalized arteriopathy. Generalized arteriopathy, not just narrowing of the aorta. Not just narrowing of the aorta. Textbooks that I've read from USMLE, MRCP, all those things, they define it as congenital narrowing of aorta at any point from the aortic arc to the iliac bifurcation. It means coarctation of aorta is not just close to the heart. It can occur at any point. However, 90% of the time, it is close to the ductus arteriosus, proximal to the distal, proximal, yeah, to the left subclavian artery. Again, although it occurs there, that point, 90% of the time, you need to understand that coarctation of aorta occurs anywhere. Can be thoracic aorta, abdominal aorta, anywhere, up till the iliac bifurcation. And there is also high association of your CoA with Turner syndrome. Turner syndrome. Again, as we understand, congenital heart diseases can occur both in adults and in children, right? However, for coarctation of aorta, the morphological manifestation and development of the disease for CoA for both adults and children is different, and they have different names too. We have about 3 more minutes, so we'll see how much we can go. In adults, the coarctation of aorta is called discrete juxtaductal coarctation. Discrete juxtaductal coarctation. And in children, it is called tubular hypoplasia. Or preductal or infantile or infantile hypoplasia. The development of the disease for both is different, and it's important to understand why they are different. Okay, in discrete juxtaductal coarctation in adults, the one that occurs in adults, the blood flows through the narrow segment from across the aorta, from ascending aorta through the narrowing, to that narrowing, and goes through it, but it there are no it travels normally, like there's no obstruction whatsoever, but there is left ventricular hypertrophy and there is hypertension. Blood will still flow normally, however the heart has problem. In tubular hypoplasia or infantile or preductal, there is a narrowing, total narrowing of the aorta up, and
You said the blood flow is normal,
normal,
but
yeah,
we have hypertension and left ventricular hypertrophy.
correct, yeah. But in children, the tubular hypoplasia, there is severe narrowing of the aorta, of the vessel, and it even extends to the ductus arteriosus. Remember, your ductus arteriosus is still intact because it occurs in children, right? In neonates or infantile. And because of this, the blood does not flow through it. Even if there's a tendency for blood to not flow through it, sometimes it can be that severe. If blood can flow through it, sure, maybe very little, but there is a high chance for it to not flow. Okay, that's a rough idea of discrete juxtaductal coarctation and tubular hypoplasia. We'll continue this next week on how on the mechanism of development of both adult and childhood coarctation of aorta, and how to diagnose and how to manage both diseases. Still still under coarctation of aorta. Okay, all right. Any questions so far before we conclude? No? All right. So that will be all for today.
Thank you.
Thank you so much for joining.
Thank you.
Thank you.
All right. Enjoy your evening.
And you too. Thank you.
That's good
Bye.
then.